Here begins videotape number 1 in the deposition of Clarissa J. Diamatides in the matter of Cynthia Allen et al. Versus Alan Burks, M.D. in the Circuit Court for Baltimore City, case number 24C15003384 MM. Today's date is January 5th, 2016. The time on the video monitor is 9:59. Our video specialist today is Sharon Rudo. This video deposition is taking place at Duke University School of Medicine in Durham. Counsel, please voice identify yourselves and state whom you represent.
Rodney M. Gaston, and I represent the plaintiffs in this case, the estate of Dennis Allen, his wife, and children.
Hello, my name is Ronald Shaw. I represent Dr. Burks and University of Maryland Medical System.
Thank you. Our court reporter today is Lisa DeGroat of DTI Global Reporting. Counsel, would you please, would the reporter please swear in our witness?
Would you raise your right hand, please? Do you swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
I do.
Thank you.
Please begin.
Madam Videographer, the rules require that you state the address that this deposition is being conducted at, and you also read into the record the case name and the case number, so that we have a clear record.
The full case name is Cynthia Allen individually and as PR of the estate for Dennis Allen et al., plaintiffs, versus Alan Burks, M.D. et al., defendant. Our physical address is Duke University School of Medicine, 411 West Chapel Hill Street, Suite 500, Durham, North Carolina. Thank you, sir.
And
in the Circuit Court for Baltimore City, case number 24C15003384 MM.
thank you very much, ma'am. Good morning, doctor. My name is Rodney Gaston, and I represent the estate of Dennis Allen, his surviving wife and children, in an action that's pending in the Circuit Court for Baltimore City in the state of Maryland. Could you please state your name and business address?
Sure. My name is Clarissa Jonas Diamatides. People refer to me as Dr. D for that reason. My business address is 411 West Chapel Hill Street, Suite 500, Durham, North Carolina, 27711.
Doctor, have you ever had your deposition taken before?
No, sir.
Okay. I'm going to go over some of the ground rules so we can get an accurate record. Although the court reporter is here to take down my questions and your answers, the videographer is also recording this. So I'd ask that you try to keep your voice up so we can capture your answers on the audio portion. And I'd also ask, so that we can get a complete record, that if you wait until after I finish asking my questions before you answer, we'll get a complete record. In normal everyday conversation, people interrupt each other all the time. But for this deposition, I just ask if you'd be a little patient. And while you're answering, I'll try not to interrupt you so we can get a full answer. Also, if any time I ask you a question that you do not understand, stop me immediately and just tell me I don't understand your question, and I'll try to rephrase the question. Otherwise, if you don't do that, we will assume that you've understood the question and you've answered it appropriately. Also, if at any time during this deposition you need to take a break, just let us know and we'll stop. Doctor, I have a copy of your resume or curriculum vitae, and it's my understanding that you have a degree of medicine from, is it Duke University?
My medical degree is from New York Medical College.
New York Medical College, okay. And did you also attend a residency at Duke University Medical Center?
Yes, sir.
And you also attended a fellowship in nephrology at Johns Hopkins Hospital?
Correct.
Okay. Are you board certified in internal medicine?
I am board certified in internal medicine.
Are you board certified in any other field of medicine?
No.
Okay. And it looks like from your resume you started working at the University of Maryland School of Medicine in July 2010, and you continued with that employment until August 2014, is that correct?
Correct.
Now, it says that you were assistant professor of medicine at that time. Can you tell me what your roles as an assistant professor of medicine included whether you taught students in the classroom, whether you taught students in the clinical field? Exactly what was your role?
So my role was, from a teaching perspective, was clinical. I am actually a clinical researcher, so a good portion of my time was done doing clinical investigation. My clinical responsibilities were in the Division of Nephrology, where I would round on the inpatient services at 3 hospitals within Maryland, which are shock trauma, the Baltimore VA Medical Center, and University of Maryland Hospital. On those services, there was always a fellow, a nephrology trainee from University of Maryland. At times, there were medical students, not consistently. I also was an attending on the general internal medicine service at both the Baltimore VA Medical Center and University of Maryland Hospital. And on those services, that included residents and medical students. I also had outpatient attending privileges where I would have a nephrology clinic both at University of Maryland and at the Baltimore VA Medical Center.
Right. It looks like with respect to your teaching duties in the field of nephrology, you had one fellow at a time?
Yes, no more than one.
No more than one, but no residents in the nephrology department?
It was variable, not consistently,
Okay.
occasionally.
All right. But no classroom instruction, all clinical, correct?
Correct.
Okay. All right. And doctor, can you tell me, did you hold a position with the nephrology service in the hierarchy, if you will, or were you?
I'm not sure I understand.
Okay. Were you the chief of the division, the assistant chief of the division of nephrology?
Oh, no, I was just a faculty member in the Division of Nephrology.
Okay. And did the nephrology service there cover all of the inpatient needs for patients at University of Maryland Hospital?
Yes.
Okay. Can you tell me, in the year 2013, approximately how many nephrologists were employed in the nephrology service?
I would estimate around 20.
20? All right. And was the nephrologist service a 24/7 service at the hospital?
Yes,
Okay.
in the sense that there was availability 24/7. There was not a actual person there 24/7,
Okay.
but we were always available by pager.
Okay. You can tell me how your schedule broke down. Did you work day shift?
Day
4 to 12?
shift.
Day
Yeah.
shift? Okay.
Yes.
All right. And how were your assignments delegated? Were you at 1 week at the VA, 1 week at University of Maryland, 1 week at shock trauma, or was there some other schedule?
Good question. I believe they were 2-week assignments. There was a schedule that was created annually, an attending schedule. There was always some variability as throughout the year, people changing. But I believe the blocks were 2-week blocks of assignments. So, for example, 2 weeks at the Baltimore VA, and then your next 2 weeks would be on inpatient, at Maryland.
Okay. Do you know Dr. Sana?
Dr. Sana, yeah. Satish Sana, yes.
Okay. All right. And Dr. Sana was a fellow in March of 2013?
Yes, I believe he would have been a second-year fellow. 14. No, excuse me, he would have been a first-year fellow. Yes.
Okay. And in order to be a fellow, you have to have completed your residency in nephrology first before you can start a fellowship program?
Your residency in internal medicine
Okay.
first.
And then the fellowship in nephrology.
Correct.
Okay. And you said you were also the attending on the internal medicine service. In this case, I understand that Dr. Burks was actually the attending internal medicine physician for Mr. Allen. Is that your understanding as well?
That's correct. I was the consulting nephrologist in this case.
Okay. Now, with respect to your physical location in the hospital, can you explain to me what your daily routine was. When you came in the morning for your shift, what did you usually do each day?
So I would answer that when I was on a clinical rotation, which is what's relevant here. When I did research, there's a lot of computer time associated with doing investigation. But clinically, we would come in the morning. We generally touch base with the fellows either by phone or in person. I usually touch base in person, where we would preliminarily, what we call run the list, which means we would look at the patients that we have, sort of prioritize who needs to be seen and when. The fellow often came in before the attending. They came in quite early. And so they had some, basic knowledge of the service, and then we would decide when we were going to round together. So the expectation generally is that the fellow sees the patients, gathers the data that's needed, and then the attending rounds with them at a later time.
Okay. Now, what was your day schedule? What time did you start in the morning?
Let's say 9.
9 o'clock.
Yeah.
Okay. All right. Now, it's my understanding that a fellow can only treat patients and write order for patients under supervision of an attending nephrologist. Is that
Correct.
Okay. All right. So, anytime there was an order for dialysis, if the fellow believed that dialysis was needed on the patient, they'd have to run it by you. You'd have to approve it before the patient could get dialysis.
So they could write orders that could be carried out. They were supposed to run things by the attending, but the order itself could be signed by a fellow. It doesn't have to be co-signed by an attending.
Okay.
The order to start dialysis,
Okay.
if that makes sense.
It does. So if a fellow, they come in a couple hours before the attendings. If a fellow came in, saw a patient, and concluded that the patient needed urgent dialysis, the fellow would be allowed to write the order for the patient, and then the patient could begin dialysis. And then after the attendings come in, the attendings would then review the order and then post-approve the order?
Yes, so we were expected to see patients while they were on dialysis, while they were on the machine. So the order can be written by the fellow, urgently or non-urgently, routinely.
Okay, all right. And in your practice, doctor, while you were at the University of Maryland Hospital,
Pardon me.
if a order is written on a non-routine basis, where the fellow believes the patient needs dialysis, not an urgent or a stat basis, and you concur, do you have a time frame when the nephrology service could begin performing that dialysis for that patient?
So that's highly variable, mostly because it depends on staffing. So the way that dialysis works is that there are two ways that we do dialysis. We do it either in the dialysis unit itself, or we do it at the bedside. And the way that we decide one versus the other is the clinical stability of the patient, who we are dialyzing, and whether they're able to transport to the dialysis unit. In an ideal scenario, everyone dialyzes in the dialysis unit itself, and the reason being is because in the dialysis unit, we need less staff to dialyze a greater number of people. So typically, a dialysis nurse would cover approximately 4 patients. That might be an overestimation. It might be 3, but 4. Let's just say 4 in the dialysis unit. They always had a tech on hand with them as well. As opposed to at the bedside, it would be 1 dialysis nurse technician with 1 patient. So as you can imagine, from a staffing perspective, it's much more laborious to have someone dialyze at the bedside.
Does if the patient is dialysized at the bedside, does a dialysis nurse and or the tech have to remain with the patient the entire time the
Yes.
patient is on dialysis?
Yes, sir.
Because you can't leave the patient.
Correct.
Okay. All right. Now, I saw a notation in the chart where next to a dialysis technician, it is CCHT or CHDT, and I'll show you what's been marked as exhibit number 2.
Okay.
is CHDT certified hemodialysis technician?
I don't know. I would presume yes.
Okay.
That sounds right.
So, can a certified dialysis technician start and finish dialysis, or does a nurse also have to be present?
So I believe at Maryland, and this is certainly not my expertise, but I believe that a nurse has to be present to start all dialysis in conjunction with the tech. The tech is available to monitor the patient during dialysis, but I believe their system was that a nurse would be there for all, to get everything set up and started, and then the tech was fine to sit at bedside. They would have to do, I believe they would like check the machines before everything started.
Okay. Now, for dialysis to be performed in the room, does the equipment itself have to be wheeled into the room, or are there particular floors on the hospital that already have the dialysis equipment in the floor itself?
Good question. No, you have to go into in the room itself with the machine. Not all rooms are capable of supporting dialysis because they have to have a certain quality to the water in the room, because dialysis is a sterile technique. So we have, so the hospital does not invest in raising the quality of the water to almost sterile conditions on all floors of the hospital. It's only in the intensive care units and intermediate care unit, and I think one other floor in the main hospital. So in order to get bedside dialysis, you have to be in one of those units so that the water quality is sufficient to support dialysis.
Okay. Now, getting back to my original question as to how long it takes for a patient to begin dialysis on a non-stat and non-urgent basis. Is there a time frame that you're familiar with? And you can talk about the two instances, one of the patient going to the dialysis unit itself and the other with the patient receiving dialysis in the patient's own hospital room.
So the short answer is that every dialysis treatment takes at least 30 minutes to prepare the machine, because they have to ensure that it's sterile, they have to run solution through the machine. It's quite a complicated process. So they start that preparation, it takes 30 minutes before you can safely hook a patient to the machine. That's, if we're talking time zero and when dialysis can start, it's 30 minutes. However, because we are talking about staffing and transporting dialysis machines different places, let's say we're talking about the bedside, you accrue time on top of that 30 minutes. So that's the minimum it could be. For example, in a routine dialysis, what we would do is we had something called shifts, dialysis shifts. And so we would characterize people as being first shift, second shift, and third shift. Routinely in the dialysis unit, first shift, meaning the first people to have dialysis, starts very early, around 6:30 or 7 in the morning. Traditional dialysis is about 3 to 4 hours. By the time the patients leave the unit, the machines are cleaned, et cetera, the second shift probably starts around 11. And then third shift starts around 3, if there's a third shift. There's not always a third shift. So if it's routine and things are scheduled, the day prior, then things could be scheduled specifically during a shift. So that's why there's a little variability in the scheduling. And bedside is the same way. So in the mornings, we would have a list of patients who would need to be done at the bedside. That would be based on our assessment the night before, let's say. In the morning, the fellow and the attendings would review, do they really need dialysis? Is there someone more who needs it a little bit more of a priority? The nurses would do that also, the dialysis nurses in the morning, the nurse manager. They would prioritize the bedside dialysis, and then it would be, first shift, second shift, third shift. Bedside dialysis is not quite as traditional as regular dialysis. The time could be shorter, for example, because oftentimes it's done more frequently. Because people are very sick, And so maybe they can't tolerate a full 4-hour dialysis session. Maybe we'll do 2 hours one day, 2 hours the next day. So there is some variability in terms of the treatment times, more so on bedside dialysis than routine dialysis. So on a routine basis, that's a traditional schedule that we have. Now, if it's, for example, in the morning, if you're the fellow and you see a new patient, you say, hey, I think this patient might need bedside dialysis today. To answer your question to the timing, it really is very contingent on that schedule that I laid out before. You know, how is this person prioritized? What's already on the schedule? Excuse me, what's the staffing look like for bedside dialysis? Because as I mentioned, it's a one-to-one treatment, etc., things like that. And so it's a bit of a moving parts. We move people around and say, well, they're not, you know, maybe this person can even wait till tomorrow if need be, or things like that, you know, if there's someone much more urgent. And that's how dialysis gets scheduled.
Okay. With respect to the dialysis unit itself, is the dialysis unit staffed on Saturday, Sunday, and holidays to accommodate the first shift, second shift, and third shift dialysis?
It is staffed on Monday through Saturday. Sunday there's an on-call dialysis technician, or nurse, excuse me. On holidays, there are 3 holidays, I believe, throughout the year. It might be 4, but it's Christmas, New Year's, and July 4th, where the dialysis unit is closed. But to make up for that, usually what we do is we dialyze on Sunday. For example, over Christmas this week, it fell on a Friday. The dialysis unit was closed, so we dialyzed Saturday and Sunday instead to make sure that we had enough dialysis treatments.
Right. Now, when Sundays, when the dialysis unit is normally closed at University of Maryland Hospital, notwithstanding the fact that the nurses and techs aren't in the unit, do nephrologists still maintain a regular schedule at University of Maryland, or is it a reduced schedule where they're only on call?
The nephrologists themselves, sir?
Yes, ma'am.
So every weekend there are 2 nephrologists and a fellow at University of Maryland seeing the patients on service in hospital during the day.
Okay, and you have to cover the whole hospital?
Hospitals, yes.
Hospitals. Oh, so you have to
the
cover
VA shock trauma in Maryland, yes.
Okay. All right. And if one of the nephrologists or fellows decides that a patient needs dialysis on a Sunday, they can use the on-call list and call the nurse or the certified hemodialysis technician to come in to perform the dialysis.
Yes.
Okay, now let's talk about urgent or stat hemodialysis.
Mm-hmm.
Let's say, for example, you get a call from the attending. They call your unit, or they page you, and you answer the page, and the attending says, you know, doctor, I've evaluated this patient. It's my opinion the patient needs urgent hemodialysis. What do you do? What is the steps that you then implement on an urgent or stat request for hemodialysis?
The next step would be to talk to the dialysis nurse manager to see what the schedule looks like right now. We would relay to them, this patient needs, you know, urgent dialysis. Then we would work with the nurse manager of the dialysis unit to prioritize treatments. You know, if need be, we could stop a treatment early, you know, if it means that we have to get somewhere very quickly. We obviously prefer not to do that because there's risks to that as well. And then basically we would prioritize the staffing and, as I said, move the parts around to make it happen as promptly as possible.
Is there ever in the dialysis unit one unit on reserve for a stat or emergency basis?
No. Very good question. No, we don't have the staffing on, you know, sort of on deck in case of an emergency.
Let's talk about
generally not.
Let's talk about the equipment. Staffing is a separate issue.
Oh,
I want to know
equipment.
if there's one unit that's on reserve for stat or emergency use only.
So they have several machines. I don't think it's necessarily machine availability. The issue is that I would say generally yes, I think that's probably the case. But again, any machine that is used has to be primed, and then it has to be sterilized after. So once it's used, it's sort of out of commission until that happens. But there are generally machines available. However, what often we do is that we use machines. The same. It's actually, in some sense, almost faster to use the same machine after you sterilize it, for one nurse to move it to different units and sterilize it and get it ready, rather than taking it to the dialysis unit, priming a new machine, per se. The nurse manager could probably answer that a little bit more specifically, but I would say it's not necessarily the availability of the machine. We reference it as, colloquially we say, oh yes, we need to get a machine available, but what we really mean is that we need the person with the machine available.
You have to have both, otherwise it won't
Yes,
work.
exactly.
No, I understand.
Yes,
All right.
that's clear. But
Doctor, have you ever prepped a dialysis machine for a patient?
No.
Okay, that's not the attending's or the fellow's job. That's the
Correct.
job that falls to the nursing staff or the tech staff.
Yes, sir.
Okay, all right. So again, getting back to the time frame, if the attending says, you know, I got a patient such as Mr. Allen, he's got irregular heartbeats, we have a potentially life-threatening situation, doctor, I need hemodialysis as quickly as you can get here. Would you then be able to call the dialysis manager, get an estimate of whether or not they have the machine and the staff available, and then be able to tell the attending, listen, I've called the dialysis manager, we are either en route now, or we can get everything down to the patient within the next hour or so. Do you have the ability to do that?
Objection is to form. You can answer.
I will say yes, with a caveat. So after a discussion with the nurse manager, which usually requires the nurse manager to then reach out to the dialysis nurses or techs who are doing the treatments to find out the status, how much longer do they have, et cetera, how the stability of the patient there, who would then find out, then obviously relay it back to us how long it might be, which we could potentially relay to the requesting team, for example. Again, there are many moving parts, and so en route is not a specific time. It's not a specific, okay, if the dialysis machine is en route, it doesn't mean without fail that it will be there within 10 minutes and then 30 minutes of prep time. It means that maybe they're finishing up the other machine and you're next on the list, for example.
Have you ever had a request for urgent or stat dialysis while you were a nephrologist at University of Maryland Hospital?
Oh, yes.
Okay. And can you tell me during those times, what is the time frame that you were able to convey back to the attending that we can get there for the patient? Give me an estimate if you could, your best estimate.
My best estimate would be probably an hour,
Okay.
which would be
And
on
so
the more prompt side of urgent dialysis.
an hour, I'm just unclear about the question. Hour from what?
An hour from the time that it was requested. So that in an ideal scenario, if we had a patient that we needed to take off a machine to put someone else on a machine, the minimum of that would be about an hour probably.
I understand.
In
Until when?
reality, until the new patient gets on the machine.
Doctor, is part of the nephrologist's role in managing the patient's hemodialysis needs to discuss with the internal medicine attending the patient's condition, why the attending believes the patient needs dialysis, and if there's a urgent situation that prompts the need for dialysis, for both the attending and the nephrologist to discuss that, to formulate a plan of care to best serve the needs of the patient?
Objection, compound. You can answer.
So if there is a need for an urgent dialysis, which I believe is the scenario that you posed, The requesting provider would need to talk to the nephrology service, yes, about why they feel it was urgent, what are their concerns, and then we could then obviously relay our expertise, whether it is urgent, is it not urgent, and as you mentioned, a potential time frame, after we discuss with the rest of the nephrology care team for us to be able to provide it if it is indeed needed. Now the first line of triage of those conversations is the fellow. So a service, if I was on with Dr. Sana, for example, in this case, he's at the end of the pager. So they would page Dr. Sana to discuss the need for X, Y, and Z. Typically they don't call the attending directly unless they couldn't reach the fellow for some reason, which is unusual, or I personally round with the attendings a lot, meaning I go when I'm in a unit, particularly the intermediate care unit, which is a contained unit, usually, and it's not steadfast, because it's a contained unit, the attendings are often, visually available. So I usually will touch base with them about our mutual patients, if that's a possibility.
Okay. Now, when you say contained unit, can you describe that to me, what the intermediate care unit is at University of Maryland back in 2013?
So it was a unit on the 10th floor of Maryland Hospital. It has about 20 beds or so. My apologies, I don't know exactly. But it is a unit where all of the patients that are cared for by the hospitalists who attend there are physically located in the same space, which is different than other services. For example, if I'm an attending on general medicine, I could have patients on 4 or 5 different floors. In the intermediate care unit, all of the patients that attending is caring for is in the physical vicinity of the attending. They're all 20 rooms. It was shaped sort of like an O, like a donut, I guess. And so, or actually maybe just a big U, and the attending's office were in that unit as well.
Now, what about the nephrologists? Was there any particular nephrologist assigned to the intermediate care unit? How did that work?
So, the way that the nephrologist schedule worked was that we were assigned, there were different services. So there was an acute service, which is, for example, the intensive care unit, of which there were many at University of Maryland. There was like a chronic dialysis service for people who had end-stage renal disease and were just in the hospital for other reasons, who would maintain that. There was I need to dust off the memory here. There was another service. There was a VA service. The reason I'm having trouble is because it's gone through different iterations of who covers what unit, and the IMC, which is the intermediate care unit, I believe fell on the more chronic service. However, I know there was one iteration where if people were requiring dialysis at the bedside, they felt that was more appropriate for the ICU attending. So I can't remember in which scenario we were during this particular rounding day, but yes, usually there is an attending assigned in general to a specific unit. That would be the general answer.
No,
yes.
An attending nephrologist.
Yes, sir, an attending nephrologist.
And would these different services fall into that 2-week rotation that you're talking about?
Generally.
Okay.
Yes.
All right. And where would the office for the attending nephrologist be if they were assigned to the intermediate care? Do they have one right inside the intermediate care unit?
No. So the nephrology office itself was in the same area of the hospital on the 3rd floor. To remind you, the IMC is on the 10th floor. And then, nephrologist individual offices were either within the nephrology office itself or scattered in other places around the hospital.
Okay. All right. Now, doctor, what I'd like for you to do is to take a look at exhibit number 2. First off, have you had a chance to review Dennis Allen's medical chart from University of Maryland Hospital for his March 2013 admission?
Yes, sir, I have.
Okay. Do you remember have an independent recollection of Mr. Allen outside of the chart?
Unfortunately, I do not.
Okay. All right, doctor. So that your testimony today would have to be based upon the information contained in the chart if I asked you specific questions about what you did for Mr. Allen?
Yes, sir.
Okay. All right. Doctor, I note on exhibit number 2, the first page, I think we have number 46 at the bottom. Would that be the initial nephrology consultation report that's prepared for every new patient in the nephrology service?
Yes.
Okay. All right. Now, and then once the initial consultation is prepared, there is on page 50 a form that says attending use only. Do you know why that form, where it says attending use only, is different from the progress note that appears on page 52? Is there rhyme or reason to that?
Yes, sir. This is one of the nuances of University of Maryland nephrology. So there are times, particularly on the weekends, where the attendings would round by themselves without the presence of a fellow. And this is the note format that attendings would write. Sometimes attendings would round without the fellow because of time and things like that. And again, this is the form they would use. If they're rounding, which is more typical with a fellow, they would use this sort of dual note, the progress note that you referred to on page 52.
Okay. Now, for a patient such as Mr. Allen, did his plan of care require a nephrologist to see him at least once a day?
Yes.
Okay. And that would be normally during the day shift?
Yes.
Okay. And then you'd follow the procedures that you already testified to with respect to the fellow usually seeing the patient first, and then the attending would come in and then meet up with the fellow?
Yes.
Okay. Now, with respect to Mr. Allen's case, let's see, hang on a second. Do you know Dr. Is it Hassan, Hisan, M. Hassan?
Are you on the...
I'm on page 49.
Oh, that's Dr. Michael Heiss.
Heiss. Okay, do you know Dr.
H-I-S-E.
Do you know Dr. Heiss?
Yes.
Was he an attending or a fellow at the time?
An attending.
Okay, all right. And with respect to some of the orders, we have, let's just go, for example, to page number 76.
You don't have an extra copy of that?
No, I don't.
Because I want to be able to follow along, and you're using a different page reference. So just tell me what you're looking at. Instead of just a page number, give me the date, what type of form it is.
Hang on a second. I'll pull it up for you so you don't have to worry.
Or I can have my own set, just identify it rather than by page number.
It's 1519 for you, 123.
Okay, 1519. Okay, thank you.
I believe that's the same. Yes.
Okay. Doctor, is that the hemodialysis treatment record that's used for all patients
Yes.
who have hemodialysis at the University of Maryland Hospital?
Yes, sir.
Okay. I note on the first page is that it has the date of today's date.
Mm-hmm.
And then it has the location. Is that the patient's location?
Yes.
Okay. And what is is that 10 West?
That's 10 West.
Okay. All right. Now, and that says for treatment on March 13, 2013.
Yes, and because sometimes we write the orders the day before. So we would say, for example, 3/12/13 for treatment on 3/13/13. This is an order that was written for the same day.
All right. How far in advance can you write an order for hemodialysis for a patient?
Generally, the day before would be the earliest.
Earliest? Okay.
Yes.
All right. So even though you don't have blood work yet for the following day, the nephrologist can, in their own judgment, decide that the patient needs nephrology the next day, even though you don't have the blood work back for that patient for that day yet.
Needs dialysis, yes.
All right. Now, with respect to these, we're still on page number 76, where it says the nurse's initials, where it says nephrologist orders. Is this the actual order for dialysis in the hospital?
Yes.
Okay. Because I note that there's some computer-generated orders, but I don't see any orders for hemodialysis that appear in the computer-generated orders.
At this time, dialysis was a handwritten order. It was a paper order.
All right. And where it says nurse's initials in that first block, and then it says date, can you tell me what that represents, the date and time where you have nurse's initials there on page 76?
So I believe that's the time that the nurse takes ownership, in some sense, of the dialysis order. It's basically acknowledging that they've recognized the order. On this particular day, it looks like they took the order, they time-stamped it at 1500, and then the subsequent page, which is 77, for you should just be the following page. It looks like the dialysis treatment started at 1505. So they signed the order and then they started the treatment.
Okay. Now, on that same page, number 76, we have ordering nephrologist, Dr. Sana, notifying nephrologist, Dr. Heiss.
Yes.
What's the difference between those two, if you can tell me?
Dr. Heiss is the attending who needs to see the patient on dialysis during the treatment. In order for a nephrologist to be reimbursed for a dialysis treatment, they have to physically see the patient on dialysis. And that cannot be a fellow. It has to be an attending.
Okay, so every time a patient undergoes dialysis at University of Maryland Hospital, an attending nephrologist must see the patient at least one time while the patient's on dialysis. Is that correct?
If the hospital wants to be reimbursed for dialysis, yes.
Okay, and that's the policy. That's
the policy, yes.
And that's what you follow?
Yes, sir. Yes, sir.
All right. Because the hospital wants to get paid. All right. All right. So, and that's the only reason why notify. So when a fellow orders dialysis, the fellow has to contact the attending to let the attending know, I've just ordered dialysis for, in this case, Mr. Allen. It's going to start at 3 o'clock. You need to be there at some point while he's having dialysis.
So typically, the fellow will notify the attending, Mr. Allen is going to get dialysis today. The attending would probably touch base with the nursing staff to find out approximately what time. But when the patient starts dialysis, the nurse or tech pages the attending and says, Dr. Heiss, Mr. Allen is on the machine. He started at 3:05. He has been ordered for 2.5 hours. And the attending would then take note. Okay, well then he'll be on dialysis till 5:30, for example. I need to see him before then.
Okay.
That's
now,
typically how it works.
Thank you. The next box where it says nephrologist progress note, who is supposed to fill out the progress note?
The attending.
Now, is that done at the time the attending sees the patient while the patient is on dialysis?
Yes, sir.
Okay. All right. So if a fellow orders dialysis for a patient for the next day, then the attending does not have to see that, well, it's not required, I guess, to see that patient for the purposes of dialysis until actually dialysis begins?
Correct.
Okay. But in your practice, I think you say you usually round with the fellows every day on your patients, correct?
Yes. So, however, if we know for sure that someone is going to get dialysis later in the day, oftentimes we'll wait until they're on dialysis before we go examine the patient, so that we don't round twice on the same patient.
I understand. Okay. Now, can you tell me the policy when a fellow or an attending nephrologist rounds on the patient in the morning? What do you always ask to see whether the morning labs have been drawn and what the lab results are?
So we go over the labs in the morning, yes, if they're available. Generally, they are available. Sometimes they are not available.
Do you check to be sure that the blood has been drawn for the morning draw?
With the nursing staff or in the...
Any way you can do it.
we check to see if the labs are back. Let's put it that way.
Okay.
If we find the nurse, we may ask, where are the labs if they are not back? I would not say that's 100%. But we do, a lot of what we do in nephrology is based on labs.
That's what I thought.
Yes,
You want to
so
know the
it's
values.
very important for us to have labs to be able to make a decision, a treatment plan.
Because the labs sort of give you an idea how good or how bad the kidney is filtering the blood, correct?
Correct.
And that would be your creatinine level, the BUN levels, and some other levels, correct?
Correct.
Okay, all right. So to make a educated choice on whether a patient needs dialysis, having the lab work back would be a very important part of the analysis.
Objection. That's the form you can answer.
Yes.
Okay. Now, normally, when you round on a patient in the morning, when do you expect to see the morning lab results back?
They're typically back by 8 o'clock, 9 o'clock. Sometimes it depends on the unit itself as to how promptly the labs are drawn. The higher the acuity of the unit, the earlier the labs are often drawn, because much of what you decide to do that day is based on those labs.
Right. And I noted in Mr. Allen's case, the blood work is usually performed at 4:30 in the morning.
And that's the traditional first sweep of the phlebotomist is around 4:30 to wake everyone up and draw their labs.
Okay. All right. Now, so if you were rounding on a patient, say 11 o'clock in the morning, and the labs weren't back yet, where you would normally expect them to be back, what would you do?
Objection. You can answer.
We would usually inquire as to why the labs were not back. And typically on patients for which it's sort of crucial to have labs, there's always an attempt to get labs at a later time, whether that's the ordering another phlebotomy draw, which is on a schedule again, and I can't recall when the next draw for phlebotomy is at the University of Maryland. Typically it's around 11 at most places. I apologize, I don't know for a fact. Or at times they're drawn, the team itself will draw the labs, but it's much preferred the phlebotomy does it, if at all possible.
If you came in, for example, in this case, when you were rounding with Mr. Allen, 11 o'clock in the morning, and the nurse told you that Mr. Allen refused to have his blood drawn in the morning, would that be something that would be very unusual?
Objection.
No.
Okay. If that happens, what's the policy and procedures at the hospital for the attending nephrologist when they learn that a patient has refused to have their blood drawn in the morning?
Well, I am not the primary attending for any of these patients. I'm a consultant. So, the attendings who are, the patients are under the care of an attending physician for the majority of the care, and we are a consultative team. So we would ask that the labs get drawn if at all possible, and then it's up to the attending team, the primary team. I keep saying attending team. The primary team to decide how that would go forth. But there are cases where patients just flat out refuse to get labs, and quite frankly, you cannot force people to get their labs drawn. So there are times when labs just do not get drawn.
I understand. And if a patient refused to have their blood drawn, is that something that the nurses are supposed to make a note of in the patient's chart?
Objection. If you know.
I can't say that I know that.
If you, as a consulting nephrologist, were informed that a patient refused to have their blood drawn, would that be something that you would note in your evaluation record?
Objection.
Not necessarily. We'd
Why not?
probably just say the labs are not back. I'm not sure we would say why they're not back. It could be, there's several reasons. It could be the patient refused. It could be the phlebotomist was unable to get the lab itself. For us, it doesn't really matter why the labs aren't back. It's just that the labs aren't back.
And then would it be your practice to notify the attending, hey, I'm the consulting nephrologist. I came down to do an evaluation whether or not this patient needs hemodialysis. I don't have the labs. I want to bring that to your attention because in this case, let's say the patient refused the labs. Would that be something that you would convey to the attending?
Objection, a compound question.
Not routinely, because often the primary team is well aware that the patient doesn't have labs. They're usually more aware of it than the consulting team, and particularly the nursing staff. They would be aware if the patient, if they did not get the labs. So typically what happens if a patient refuses labs, I believe a phlebotomist notifies someone, the nurse, that the patient refused their labs, or whomever was supposed to gather the labs. Again, it depends on the unit who's taking the labs, but generally it's a phlebotomist, and they would notify the primary team. I didn't draw labs because he refused.
So was it your practice at University of Maryland when you discovered, when you rounded on a patient at 11 o'clock in the morning to make a decision whether they needed hemodialysis that day and found out that the patient refused the lab work the morning, that you would not reach out and contact the attending?
Objection.
I would not say it was, I don't think I could comment on what would be standard practice. My assumption would be that there was confirmation that the team did not know there were labs and that he needed labs. He needed labs for many reasons, not just for dialysis, but
well, my question would be, if that happened in your case for one of the patients that you consulted on, is it your testimony you would not reach out to the attending and let the attending know that situation?
Objection.
it would not be routine practice for me to reach out directly to the attending. More likely, either myself or the fellow, as we were rounding, would speak with the nursing staff and find out why he didn't get labs, because they would be most aware.
Okay. In that situation, could you order labs yourself?
No,
Can the fellow order a blood drawn?
no. We do not order labs on patients that we are not taking care of as primary team.
If you believe the patient needed a lab test stat or urgently, and labs weren't performed that morning for whatever reason, what would you do if you believe the patient really needed that right away?
Objection.
Again, we would tell the primary team that we feel he needs urgent labs, or the patient needs urgent labs. Whether that primary team is the nurse or the attending, is probably variable depending on the context of.
Would you make a note?
Situation.
Would you make a note in the chart of that conversation or of that notification?
Probably, I would not. Probably not.
Okay. And if your decision whether or not the patient needed hemodialysis could not be reached at the morning rounding because there were no labs, what would you do for the remaining of your shift with respect to that patient?
We would probably frequently check to see if the labs were back, remain in contact with the primary team as to whether they are pending or cooking, as we say, in the lab cooking. The labs are cooking, meaning they're drawn but have not been processed yet, or what the plan is to obtain labs at that time.
Okay. In this case, I want to draw your attention to March 18th, where we have, let me see if I have your, do you have a progress note for the March 18th rounding on Mr. Allen? It's at page 52 of Exhibit 2.
52. Oh, yes. Got it, sir.
Okay.
I think page 1533 of our records.
Yes. 1533, yes.
Okay. Can you tell me whose handwriting is on that first page?
On the left column, it's Dr. Sana, and on the right column, it is mine.
Okay. Now, on the second page of this daily progress note, at the bottom, is that your signature, doctor, on the left-hand side where it says signature of attending physician?
Yes, sir, it is.
Okay. Now, even though it says signature of attending physician, were you technically Mr. Allen's attending physician? Or is
Objection.
attending, I'm just trying to figure out, it says attending, and then you said, well, we don't usually contact the internal medicine doctors if we're only consulting. So I'm trying to figure out the distinction where it says signature of attending physician on that page.
Sure, I understand. It means the attending nephrologist.
Okay. Now, and there's 3 boxes there, boxes for you to check depending upon which situation applies. And I believe you check the box that says, I personally perform the key portions of the H&P, is that history and physical?
Yep.
And reviewed the fellow residents' documentation.
Yes.
Okay. Is that how the fellowship program works?
Yes.
Fellow comes in, he makes his notes, and you go in, you review his notes, you do your own assessment of the patient, and then you make your own observations and assessments.
Correct.
Objection.
Correct.
Now, the top of the page, it has the date of 3/18/13.
What page are we talking? The first page?
Yes. Yeah.
Okay,
first-
you're
first-
moving back and forth.
I am.
All right. So
It's page 52 on my note. Page 52 in exhibit number 2. It says time 11:30 hours. Can you tell me from your knowledge and experience of filling out these forms, does the fellow usually do the evaluation and then come back and then write the assessment after the evaluation?
That's a very good question. And what I would say is that it varies. And let me explain. So sometimes the fellow would go and see the patient, do their assessment, but not document their note, particularly if labs are pending sometimes, until later. Now that later could be even before the attending comes to round. It could be concomitantly while rounding with the attending. They could be finishing their note, for example, while I'm examining Mr. Allen. There is some variability. There are times, depending on the bulk of our service, where we would round together. It could be on this morning I told Dr. Sana, let's go see Mr. Allen, and at 11:30 we went over there and saw him together. Unfortunately, I cannot recollect in this specific case the timing of our rounding.
All right. Well, let me see if I can ask the question another way. Dr. Sana would not be able to fill in all of the handwritten notes on the first page of the progress note until after he concluded his evaluation of the patient. Would that be a fair statement?
After he saw the patient, he can write this portion.
Now, and it looks like when he wrote the time 11:30 hours, is it safe to assume that the evaluation was at least concluded by 11:30 a.m. that morning?
Yes.
Okay. Now,
Yes.
with your evaluation, do you know whether your evaluation was done by 11:30 or not?
Unfortunately, I do not. My presumption is that we may have rounded together, or he wrote this at the time that we were rounding, and the reason being is that labs, as I mentioned, come back fairly early, and if they're not back by 11:30, clearly there's a reason the patient refused, or they couldn't get it. And at the time that I saw him, the labs were still not back. However, in reviewing Mr. Allen's records, I believe by 1:30 or so there were some labs back. This is, around the time that dialysis was started. I'm not sure. So we would have been aware of labs. So my assumption is this is before 1:30. I think at that time he might have already been on dialysis. But unfortunately, to answer your question, I just don't know at what time I physically saw Mr. Allen.
All right, so we need to be more precise when you get about the starting times. It's in the records when these various things started, so don't make assumptions. Let's refer to the records, please.
Okay.
In answering this question. So that wasn't his question, but...
We'll go to the
I know,
exact
but-
times very shortly,
right.
Doctor.
Okay.
So we're going to go over the hemodialysis treatment and things of that nature.
Okay.
On the second page of the March 18th progress note, which bears your signature at the bottom.
Yes, sir.
At the top it says labs. There's the initial P there. Is that the symbol for that the labs were pending.
Yeah, P with a circle around it means pending.
Okay. And also on the assessment plan, where we see Dr. Sana on number 3 and number 4, can you read his writing with respect to the words he printed on number 3 and number 4?
Yes, it says, number 3 says acid base, and number 4 says anemia, and then he has sort of a caret, and it says labs pending.
Okay. Is your understanding from the P that's circled at the top and the doctor's handwritten notes of labs pending that he was waiting for the lab results to come back from the lab?
Yes.
Okay. And was that your understanding when you saw Mr. Allen as well?
Yes, sir.
Okay. And is there anything on the first page of the nephrology progress note or the second page of the nephrology progress note that indicates that Mr. Allen refused the blood draw in the early morning hours on the 18th?
No.
Okay. Yeah. And what was your assessment of Mr. Allen on March 18th, 2013?
Could you be more specific?
Yeah, it's right here in the report.
You want me to read this?
Well, if you have no recollection of this, and this is and you can only testify from the chart, why don't you go ahead and read that to me and explain what your writing means?
Sure. So I wrote number 1, AKI, which stands for acute kidney injury. Last hemodialysis 3/16/13. Monitor labs today to assess for RRT need. RRT stands for renal replacement therapy, which is a form of one of which is dialysis. Number 2 says metabolic. He's on Foslo, which is a medication for elevated phosphorus. Number 3, rhabdo, possible muscle biopsy. Number 4.
What does that? What did you mean to convey when you said rhabdo, possible muscle biopsy? There was in reviewing the records, I saw that rheumatology was seeing him. Rheumatology are they are the specialists in something called autoimmune diseases, and oftentimes if people have a problem with muscles, they can get involved to see why they might have an inflammation. And this is saying that per the chart or per discussion, there was a plan for a possible muscle biopsy in Mr. Allen's case to determine the etiology of his rhabdomyolysis. Thank you.
And number 4 says blood pressure monitor for hypotension given his clinical illness.
Okay. All right. Now, understanding that the intermediate care unit is a telemetry unit?
Yes, I believe it is.
Okay. Now, is part of Dr. Sana's evaluation and part of your evaluation to check the status of the cardiac monitor to see what's happening with Mr. Allen's heart?
Not generally.
Okay. Can you go back to page 1, first page, which is page number 52 of the
note.
March 18th note?
Okay.
Right. Where it says on Dr. Sana's note on the left-hand side, it says cardiovascular.
Yes.
Can you tell me what those what's documented there?
Sure. It says S1, S2. I don't know what that other symbol is. That's the heart sounds. S1 and S2 heart sounds.
Okay.
Similarly on mine, it's scribbled there too. S1, S2 distant, meaning his heart sounds were distant.
Okay. Why don't we go ahead and go to your handwritten notes on the first page of the progress note, and we can go at the top. If you could just read what you wrote there.
Sure. My chicken scratches here. 63-year-old African-American male with HCV, which stands for hepatitis C virus, MPGN, which stands for membranoproliferative glomerulonephritis, recent hemodialysis, admitted with rhabdo, complicated by acute kidney injury requiring renal replacement therapy.
Okay, and what were the results of your physical examination on the same page?
Drowsy but arousable, lungs coarse, S1, S2 distant, abdomen distended, non-tender, extremities 2+ edema, right internal jugular triple lumen catheter.
Doctor, I'm trying to understand when you do a physical examination of a patient as part and parcel of your nephrology consultation, do you evaluate the patient's cardiovascular status?
We evaluate, we do a physical cardiac exam, meaning we place our stethoscope on the heart, but we don't look at the telemetry readings typically. That's not our, that's not the scope of what we do.
Were you trained on being able to identify abnormal heart arrhythmias during either your residency, internship program?
Yes.
Okay. So what I'm trying to figure out is, later on in the day around 12:30, according to the chart, Mr. Allen developed some cardiac arrhythmias. Did you see that in the chart?
Yes, sir.
What I want to know, did you see that or make a note of that during your physical examination of Mr. Allen?
Objection is to compound.
Based on what I wrote here, no. And my extension of that response would be, per what was written here, he had, sounds like 2 cardiac issues. One was bradycardia, which means a slow heart rate. In this note documented by Dr. Sana, his pulse, where it says heart rate there, was actually 76, which is not bradycardic. That is a normal heart rate. The second cardiac arrhythmia that was noted was peak T waves, which is something that would not be ascertainable by auscultation. That has to be evaluated on an EKG or ideally an EKG. Even rhythm strips are not super great at picking up peak T waves. Sometimes you can have an inclination that there's an abnormality. But that part of the arrhythmia is not, I shouldn't say arrhythmia, it's electrical disturbance, pardon me. We cannot pick up just by auscultating the heart.
Okay. My next question is there anything about Dr. Sana's physical examination of Mr. Allen and your physical examination of Mr. Allen that caused you to believe that there was any electrical changes in Mr. Allen's heart that placed him in a life-threatening situation?
Based on what I see here, no.
Okay. If there had been, would you have contacted the attending?
Certainly.
Okay. All right, thank you. All right. Now, do you know if you actually spoke to Dr. Burks on March 18th?
Unfortunately, I do not.
Okay. If you had, if there'd been a conversation with Dr. Burks, would that be something that would be found somewhere in the chart, somewhere in the note?
No. That would be, for example, my going to the attending room and saying, hey, Mr. Allen needs labs today. Just, for example, if I was directly talking to him, oh, he looks okay, we really would like to see some labs. That would kind of be the extent of our conversation. And it wouldn't be, that conversation is not documented.
Right. My next question is, other than the documentation that we find on pages 52 and 53 in Exhibit Number 2, which is the daily progress notes on March 18, 2013, does the record, as far as your review, contain any other notes that you made for Mr. Allen on March 18, 2013?
No, sir.
Is an attending physician, such as Dr. Burks, permitted to order hemodialysis for a patient under his care?
No.
Okay. That could only be done by contacting a fellow and in conjunction with the attending nephrologist review of the fellow's assessment.
Correct.
Objection.
All right. Doctor, is hemodialysis used, can it be used to reduce levels of potassium in a patient's body?
Yes.
Okay. And are you familiar with the medical diagnosis of hyperkalemia?
Yes.
Have you treated patients who've had hyperkalemia?
Yes.
So would it be fair to say you're well versed in the signs and symptoms of hyperkalemia and you're well versed in the treatment protocols for hyperkalemia?
Yes, sir.
Okay. Back in 2013, what is your understanding of the protocols for the treatment of a patient with hyperkalemia, such as Mr. Allen at the University of Maryland Hospital?
My understanding in reviewing and preparing was that there's actually an order set for the treatment of hyperkalemia, which included several established modalities. One of them was calcium. It included insulin and glucose. I believe it had albuterol on it and Kayexalate. Finally, I don't know if there was Lasix, which is another potential treatment for hyperkalemia. I can't recall if that's specifically on the order set that Mr. Shaw and I reviewed.
Okay.
It wouldn't have been appropriate on Mr. Allen because he was not making much urine.
Okay. If you, upon your consultation for a patient such as Mr. Allen, determined that he had irregular impulses of the heart, that he was hyperkalemic, and that he needed emergency measures in light of his heart situation, what, if anything, would you recommend to the attending?
Objection. You can answer.
So if it was a patient for whom, dialysis was a possibility, actually, and irrespective of that, we would probably try some temporizing measures, which are the medical therapies, which were on the order set.
And when are you talking about all of? Go ahead, Doctor.
Excuse me, I'm sorry, I didn't mean to interrupt.
Mm-hmm.
Traditionally, calcium to stabilize the heart membrane, insulin and glucose, albuterol to drive potassium back into the cells where it's come out from, Kayexalate to get rid of the potassium from the body, if at all possible, and then Lasix to help pee out potassium, if that's a possibility. It all depends on the acuity and the severity of the hyperkalemia, and then pending the outcome of those, dialysis is also a possibility. But in patients who have acute electrical abnormalities related to hyperkalemia, because of the reasons that I mentioned before, the timing of getting someone on dialysis 30 minutes at the fastest, almost exclusively we would treat with medical therapies prior to the initiation of hemodialysis.
And it's my understanding that either calcium gluconate or calcium chloride, if calcium gluconate was not available, could be administered to a patient to treat acute hyperkalemia?
So it is part of the protocol in the sense that it stabilizes the cardiac membrane. It does not change the potassium levels in the body. It is supposed to reduce the sensitivity of the heart muscle to being surrounded by so much potassium.
Right. And that would be an immediate, although temporary, stopgap for the electrical changes in the heart caused by the elevated potassium levels.
Yes,
Objection is to form.
it's a temporizing measure. Temporary.
So if your hemodialysis, the fastest you can do it on the best day is 30 minutes, then a physician could order calcium gluconate or calcium chloride to be administered immediately, which would act as a stopgap measure until dialysis could be started.
Objection.
So I don't think anyone would order just calcium. These are sort of done in conjunction, particularly the insulin and the glucose and the albuterol, because while the calcium would reduce the sensitivity of the heart muscle, it doesn't reduce the potassium itself. You're still sitting in an environment with very high potassium. And so at the same time, people would also usually give those other measures to try and push potassium into the cells for a short period of time, so that is not available to your heart and the rest of your body to cause damage. But those, again, are temporary measures.
Right. And Doctor, were you aware of the FDA warning pertaining to the drug Kayexalate when you were the consulting nephrologist for Mr. Allen on March 18, 2013?
So I cannot say that I was aware of a specific FDA warning for Kayexalate that came out in 2009. I was aware of concerns regarding bowel sensitivities and Kayexalate.
That would be bowel ischemia?
Bowel ischemia, yes.
Okay. So that was a risk that you were aware of in March of 2013. Would that be a fair statement?
Objection.
Yes, sir.
Okay. Did any doctor, Dr. Burks or Dr. Santa, discuss with you any treatment for Mr. Allen in light of his elevated electrical heart activity that occurred somewhere between, well, it was measured on the EKG, I think, around 12:30. Did any doctor discuss that with you?
Objection.
I have no recollection.
Okay. Have you ever ordered Kayexalate for the treatment of a patient with medical conditions similar to that of Mr. Allen?
Yes.
Okay, and how many times?
How many times I've ordered Kayexalate? Probably on the verge of 200. How many times have I ordered it in scenarios similar to Mr. Allen? I probably could not reference a number because there's so much variability with clinical. If I were to say broadly in terms of people who were, fairly ill, probably two dozen times, and that's just a guess. I'm sorry.
And are you able to tell us how quickly or how slowly Kayexalate works once it's taken by the patient in order to reduce the potassium levels?
So it's variable because it is dependent on a bowel movement for it to have effect. Therefore, if you take it and you don't have a bowel movement with it, it doesn't really work that well. So generally, let's say a person we gave Kayexalate and then they subsequently had a bowel movement. It could be potentially, I would say maybe 2 hours. But again, there have been instances where there was no bowel movement and we would even redose Kayexalate.
What I'm trying to figure out is, assuming the patient has bowel movement within 2 hours, have you then, after that 2-hour period, go back and done a blood test that quickly to see the reduction in the potassium levels as a result of the Kayexalate?
Yes.
Okay, and what reduction have you seen in your practice?
I'm not sure I could give you an accurate perhaps a milliequivalent of potassium, perhaps less, perhaps more. Again, some of it depends on what's causing the high potassium in the first place. If that's ongoing, or if you're in steady state, or that insult is continuing, perhaps a milliequivalent.
And is it also difficult to determine the reduction of potassium solely attributed to the administration of Kayexalate, because oftentimes in these patients you also given all of the other medications in order to help reduce the potassium levels?
Objection.
Well, the difference being that those measures are fairly temporary. So after a certain period of time, the expectation is that those measures are not working anymore. Whatever effect they had is gone. So if we're talking about a time frame of 2 hours, then certainly, the insulin and the glucose and the albuterol are probably not taking effect at that point, and any reduction would be attributed to Kayexalate. Broadly speaking, is there a way to determine what's causing the potassium to go down itself? No.
Okay. And then if you add dialysis on top of that, that's just another method of the reduction of potassium that's difficult to separate what reduction is caused by dialysis versus Kayexalate when they're used together at the same time.
Yes, sir.
Objection.
Sorry, yes, sir.
Yeah. Is there a particular level of potassium that value for potassium that was deemed to be high or critical at the time you treated Mr. Allen?
I would refer to the lab standards themselves, which are sort of different at each hospital. In general, the concern is when there is evidence of electrical abnormality that is thought to be very advanced, severe, critical. I would call that critical, hyperkalemia. For example, you could have a patient with the two patients with the same levels of potassium, one of which has normal heart electrical conductance, and the other one has an EKG with lots of abnormalities. And within those two people with the same levels of potassium, the one with the cardiac issue is much more urgent than the stable one.
Because elevated potassiums can affect different patients differently with respect to the electrical heart rhythms.
Yes, sir.
All right. Do you know if there was any policy in effect at University of Maryland Hospital at the time you treated Mr. Allen with respect to giving or not giving Kayexalate to a patient who had acute hyperkalemia when dialysis was readily available?
No.
Do you know Dr. Moyetti?
No.
Have you heard or read anything regarding Dr. Moyetti's position or opinions with respect to using Kayexalate to treat patients with acute hyperkalemia?
As of March of 2013?
Yeah, as of March of 2013. No. Do you know whether the Kayexalate that was available at the University of Maryland Hospital on March 18, 2013 contained sorbitol?
I do not.
Do you know why Kayexalate mixtures contain sorbitol?
To promote the bowel movement.
Okay. Now, on page 51, which is the March 17th attending doctor's report for Mr. Allen.
Yes. Dr. Heiss.
Dr. Heiss. Okay. Can you interpret and read Dr. Heiss's handwritten notes for us?
Sure, I can try here.
Okay.
The assessment and plan, sir?
Yes, ma'am. Yes, ma'am.
Number 1, AKI, which stands for acute kidney injury. Currently on dialysis, monitor for return of function. Number 2, bone disease, continue Foslo. Number 3, increased CPK, which is basically rhabdomyolysis. Rheumatology consult. Number 4, hypertension, I believe that says. Titrate meds. Number 5, lethargy, trial of lactulose.
Okay. Can you tell us what the trial of lactulose was for in response to doctor's assessment of lethargy?
So, in reviewing the chart, Mr. Allen, I believe, had advanced liver failure due to hepatitis C. And so one of the consequences of that is a condition called hepatic encephalopathy, where you become confused because you accumulate something called ammonia, which causes you to be confused. And one of the ways to get rid of ammonia is to use lactulose to excrete it in your bowel movements. So it's a fairly standard therapy that people use for hepatic encephalopathy is lactulose.
Doctor, during those times where you have recommended Kayexalate for your patients, have you reviewed with the patients the material risks associated with Kayexalate?
No.
Why don't you review the material risks associated with the use of Kayexalate when you recommend that your patients take Kayexalate?
Objection. You can answer.
We don't typically review the risks of every medication that we give people in the hospital. We give several medications, all with risks, and we don't go through each one and go over the risks of each one, Kayexalate included.
Can we go to page 84 in exhibit number 2, which is the hemodialysis treatment record dated March 18, 2013?
Yes, sir.
Okay. Now, according to that note, is any of your handwriting on the first page of that hemodialysis treatment record?
No, sir.
Where it says nephrologist, progress notes, can you tell me which doctor signed that?
It's Dr. Klassen.
Okay. On March 18th, according to this report, would it be accurate that Dr. Sana ordered dialysis for Mr. Allen at 1:30 p.m.?
Excuse me. Yes, sir.
Okay. Now, notify nephrologist is Dr. Klassen. I thought that you were the attending nephrologist that day for Mr. Allen.
Unfortunately, I cannot recall why Dr. Klassen was seeing Mr. Allen in the afternoon and I was seeing him in the morning. At times, we covered services for each other due to clinic, and it could be that I was covering Dr. Klassen in the morning, or that
Or Mr. Allen, you mean?
no, that I was
Or covering
covering.
for.
I was
Okay,
rounding
sorry.
in for Dr. Klassen in the morning, or he was rounding for me in the afternoon, and unfortunately I don't have any recollection of that date, and I don't have access to my calendar on that date either.
Okay. Now, so it looks like if we follow the protocols, where the attending has to be notified when a fellow orders dialysis or recommends dialysis, that Dr. Klassen was then the attending for the afternoon hours on March 18th.
It appears so, yes.
Okay. So that means Dr. Klassen would have to at least come by at one time to see Mr. Allen during his dialysis treatment if the hospital wanted to get paid for the treatment.
That's correct.
Objection.
Okay. And is there another reason that, other than the fact for monetary reimbursement, is there another reason behind the policy that the attending nephrologist has to check on the patient at least one time during the dialysis treatment?
To assess their clinical stability, of course, but they do have a primary team. Again, we're not the primary team, so traditionally in dialysis that's done in the outpatient setting, there is not an attending nephrologist present for dialysis treatments. They round once a week at the maximum. So there are several instances where people undergo dialysis and the attendings do not see them on dialysis. This is just the policy of University of Maryland, per se, to see them on dialysis.
Okay, so let's go back to page number 1 for the hemodialysis treatment record on March 18, 2013, which is page 84 of Exhibit 2. It looks like the nurse initialed the order for dialysis at 14:47, which would be 2:47 hours.
Yes.
Can you tell me why there's an hour and 17-minute lapse between the time Dr. Santa ordered the dialysis and the time that the nurse accepted the order for dialysis?
So I cannot speak to the difference in time. I can say that she signed the orders at the time when she started the treatment, which is on page 85. It was started at 14:45.
Would it be fair to say at the time Dr. Santa ordered the dialysis at 13:30 hours that in accordance with your understanding of the policy in place at University of Maryland Hospital, he would have notified the dialysis manager and told the dialysis manager that Mr. Allen needs dialysis at this time?
Yes.
Objection.
Okay. Now, is there any way to determine from the hemodialysis treatment whether Dr. Santa ordered the dialysis on an urgent or stat basis?
We cannot tell from this. What we can tell is that it was ordered at the bedside, which is what this term, if you look at the very top, it says acute. That means at the bedside.
Okay. If you order dialysis for a patient on a stat or urgent manner, Would you make a note in the chart of the stat or urgent manner?
No.
Then how would anybody know?
nurse-
hang on a second, let me finish.
Okay.
How would anybody know by looking at this treatment record, hemodialysis treatment record, whether or not Dr. Santa ordered dialysis for Mr. Allen on an urgent or stat basis?
They could not know from this record.
And then it's my understanding that neither the fellow nephrologist or the consulting nephrologist make any other notes in the chart with respect for the order of hemodialysis other than what's contained in page 84 or 85. Would that be a fair statement?
Correct, unless there was an assessment in a progress note early, plan on urgent dialysis. It's just the timing of the notes. But looking at this order, no, sir, you're
Right.
correct.
And we've also previously talked about the progress note for that same day for that same patient, correct?
Mm-hmm. Yes, sir.
And in accordance with that progress note, there is actually no order for dialysis for Mr. Allen by either Dr. Santa or yourself at the time you rounded on Mr. Allen during the morning hours. Would that be a fair statement?
That's correct, because the notes reference his dialysis need is contingent on his labs.
Right. Okay. Can you interpret Dr. Klassen's handwritten notes on page 84 where it says the nephrologist progress note?
I can try here. Yes, it says chest clear, heart regular, abdomen non-tender, trace edema, D class and MD.
And it looks like from the hemodialysis treatment record, which is page 2 of the March 18th record, on page 85, it looks like from the initial section on the very right-hand column, it's KL, KL, KL all the way down. And in accordance with the signature box at the bottom, it looks like KL is the abbreviation for the nurse's name, and her title is RN. Would you agree with that?
Yes.
Would you agree, according with the chart, that there was no certified hemodialysis technician that performed hemodialysis on Mr. Allen on March 18, 2013?
Yes.
Now, can a technician perform the hemodialysis solely by himself or herself, or does a nurse always have to be present if a hemodialysis technician is going to be participating in the hemodialysis?
So again, my understanding, and again, this is something that I would refer you to the dialysis unit itself, is that a nurse always supervises the tech in the sense that they assure that, and I believe it's usually at the beginning of the treatment, I'm not sure if they do it again at the end of the treatment, to make sure that, everything is correct. It's akin to a fellow and attending, the tech and the nurse.
The nurse performs the supervisory function?
In some cases, yes.
Okay.
Or they do it on their own.
All right. Is there any other record in the nephrology department that either by computers that we don't have with us where the dialysis manager enters in the computer a request for a stat request for hemodialysis?
Not to my knowledge.
Okay. So pretty much the only thing we have to go on is the paper chart that you reviewed. Is that correct?
Yes, sir.
Objection is to form.
All right. Doctor, is there anything else that you can, did you have anything to do with Mr. Allen's care after March 18th, 2013?
No, sir.
And did you have anything to do with this care before March 18th, 2013?
I do not believe so, no.
And would it be fair to say that you have no recollection of any conversations with Dr. Burke?
That would be fair to say, yes.
You have no recollections with any conversation with Dr. Sana?
No, sir.
Nor with Dr. Klassen?
No.
Nor with Mr. Allen?
No, sir.
Is there any other policies and procedures that you are aware of that were in effect at the University of Maryland Hospital on March 18, 2013, with respect to stat or urgent requests for hemodialysis for a patient that you haven't already explained to us in this deposition?
Objection.
No, sir.
Do you know if there are any written policies in place for stat requests for hemodialysis?
I do not. I do not. If they existed, again, they would be housed within the dialysis unit, staffing themselves, which would fall under the dialysis nursing component.
And were you aware of any other policies or procedures I think I've already asked you this question, I'm going to ask it again, I'm sorry. Were you aware of any other policies or procedures in place at University of Maryland Hospital pertaining to the use of Kayexalate for the treatment of acute hyperkalemia?
No.
Okay. All right, I'll just need about, we take maybe a few minute break. I'll review my notes, but I think we're almost done, unless council has some questions for you.
Going off record, the time on the monitor is 11:36. Take a stop.
Spell classy.
KLA.
Going back on record, the time on the monitor is 11:40. Please continue.
Doctor, would it be fair to say on March 18, 2013, that you approved Dr. Sana's assessment and plan of care for Dennis Allen?
Yes.
Do you intend to give any opinions in this case?
No.
Well, you know, if asked,
Well,
that's really not a decision for her to make.
Well, I need to know, do you intend to give any opinions with respect to any standard of care issues in this case?
No.
So, well,
Do I?
she may, but we're not at the point of identifying experts yet, so that decision hasn't been made.
Well, the only reason I'll ask you, doctor, is because have you reached any opinions on the standard of care in this case as of this date?
So she's not been asked to do that. Her role, sir, right?
Please
So-
don't. It's
no,
a speaking objection. I will object to.
I'm not telling her what to say. I'm
Well,
telling her the basis. I'm not telling her. I'm not putting words in her mouth. I'm not doing a speaking objection. She's here to testify because you insisted on taking her deposition at this point as a treater. Whether she's going to be identified as an expert or not remains to be seen. That decision hasn't been made. If she's identified as an expert, I certainly recognize your right to take her deposition on her expert opinions. But at this point, she's being produced only as a fact witness and a treating physician.
Doctor, the question stands. Have you reached any expert opinions in this case with respect to the standard of medical care?
And I'm objecting and telling her not to answer that question for the basis I described immediately prior to that question.
Okay. That's all the questions I have.
I have no questions.
Here marks the end of tape 1 and the deposition. Going off record, the time on the monitor is 11:42.